Thank you everyone for joining us today. My name is Megan Williams and I'm the Director of Support Services at Alzheimer Group. If you're joining us for the first time, at Alzheimer Group, we support people living with dementia and their family caregivers. We have family counseling support groups and different programs for caregivers, as well as a person living with dementia, including a virtual and in-person activity center. Today's lecture is made possible by the generous support of the Lindsay Memorial Foundation and the Lasner Learning Center. AGI is a charitable organization and we rely on supportive donations. This is a free lecture, but if you want to donate at any time, simply call our office or visit our website. Just to let you know how today's lecture is going to go, everyone will be left on mute. If you have any questions for the speaker, we are going to save those questions until the end. And you can write it in the Q&A or in the chat function. And I will be asking those questions after about 45 minutes. So without further ado, I'd like to introduce Sylvia Davidson. Sylvia Davidson is an occupational therapist and a manager and professional practice chief of occupational therapy, physiotherapy, and therapeutic recreation at Baycrest Health Sciences in Toronto. Throughout her career as an occupational therapist, she has worked clinically in acute care, rehabilitation, long-term care, and in the community. Sylvia is currently the chair of the Canadian Association of Occupational Therapists Dementia Network. She is also the vice president of the Canadian Occupational Therapy Foundation and a past president of the Ontario Society of Occupational Therapists. She believes passionately in the role of everyone has to play in good dementia care in partnership with persons with dementia and their individual support systems. I will let you know that you're in for a treat today because I've heard Sylvia speak before and she's fantastic. So today she's going to be talking about dementia, intimacy and aging. And without further ado, the floor is yours, Sylvia.
Thank you, Megan. And I'm super excited. Megan has already told me how many people have registered for this session, and I think that's fantastic. I am so honored to have been invited to join you all. In my career, which Megan shared with you, as an occupational therapist, working specifically with older adults throughout my career, the topic of intimacy, sexuality, sexual expression has come up over and over and over again. And every time I think I've kind of wrapped up that phase of my career, it pops up again. And so today I want to spend a little bit of time talking about intimacy and aging, but we're going to have a focus on what it really means to have this kind of a conversation when we're concerned about the issue of dementia. And you can see that what I've done today is I've entitled the talk Intimacy and Aging, Having Hope. And when I was invited to join AGI, I did go online and I took a look at what was on the website about AGI. What an amazing program, and how fortunate you are to have this kind of support for all of you. I was really struck by a couple of things in the opening sort of mission and vision for AGI. The fact that it talks about the quality of care being characterized by joyful, loving interaction. Some of the words in this slide just speak directly to why I feel so strongly about the need to talk about intimacy and aging, especially when we're talking about good dementia care. Because if we're talking about interaction, we're talking about connecting. We're talking about people finding a way to have relationships with each other. And that's really what I hope a lot of us will take away from the conversation today. And I do want it to be a conversation. The other thing, the reason that I say having hope is because hope actually comes up here as well. You talk about the hope that regarding the journey, and you talk about hope for a cure. And I think hope is a really wonderful word to have in the back of our minds when we talk about this. I will be honest, I think we have to be a bit blunt about the topic, and I will be blunt. I have a lot of slides, and because the session is being recorded, you will have access to the slides afterwards. So what I am going to do, I'm just being honest, I'm going to speak rather quickly about some of the slides, not spend a whole lot of time on some of them, because what I'd really love to do is work through the majority of the slides and then give an opportunity for some discussion. I hope that some of you will feel brave enough and comfortable enough to actually ask a question or share an experience or a thought that you might have, to disagree with me if you don't agree with something that I've said. Because I actually think that my objectives today are that we really consider some of the myths and the realities, nothing to do with dementia, just about sexuality and aging, because that's where I think the problems with this often start. I think we have to identify our own barriers, our values and beliefs, and really have more comfort when we consider the sensitive issue of intimacy. That's what today is about for me, and I hope you will get some of that out of the talk. We start with myths and realities, because you cannot talk about intimacy when you start talking about aging without addressing the myths. Sex is only for the young. That is a myth. And anyone in the audience, I can't see you all, but if you're not considering yourself a youngster anymore, then I hope that you would also challenge that myth. Although, as much as we say that we are an enlightened society, as much as the free love of the hippies and the flower children in the 60s really was supposed to broaden our view of everything in the world, my sense is that something about intimacy, especially when we talk about it in relation to older adults, still is not acceptable in many realms of society. And unfortunately, a huge chunk of that problem exists within healthcare. So I think that's a problem, and I think that it's important that we talk about it. And I am going to get to that throughout the next hour that we have together. Another myth, it's not physiologically possible. Many of us do see the signs of our bodies starting to give up on us. You see how you get sick and you don't bounce back like you used to. It takes longer to recover from injury. Indeed, there is much about the human body that physiologically deteriorates with advancing age. That does not mean that you cannot still be intimate, that you cannot still find pleasure in companionship, in closeness, that you can't indeed even have intercourse if that's what you're seeking. But that's not what we're talking about today, because in my opinion, intimacy, this topic is much, much, much broader than that. The other point on this slide, that institutionalization, equals the end of sexual freedom. That's not a myth. That actually is pretty much a reality. And anybody who spent any time in a hospital, anybody who is in a long-term care home or has a partner in a long-term care home, knows what happens when you become institutionalized, the lack of privacy, the need to be dependent on others for so much that you would never have had to ask permission for before. This is a fact. And in addition, when we speak about institutionalization in particular, we have to now start to realize that some of the things we may need to do and want to do are dependent on other people who are responsible for how we get through our day. Every one of us has values and beliefs. And when we talk about intimacy, those values and beliefs can influence how we react. Now I'm thinking very much about what happens when a personal support worker working night shift in a nursing home goes in to check on one of his or her residents and finds them in bed with somebody else. And that can lead to a cascade of events that can often become, awful, just awful. And I think that is, in the time that I worked in long-term care, that was something that I was often asked to come in and fix, the problems around people in bed together, people seeking out companionship with others, and how could we stop it and correct it. And I'm here to tell you that I'm not a fan of the stopping and the correcting. However, I do believe that we have to be prepared to be open, to take a step back from the emotional response that we're having to something because of our values and our beliefs. I think we have to respect the other people who are involved in the conversation if we're having a conversation about this topic. Every one of us is entitled to our opinion. And no matter how broad-minded everyone thinks they may be, it's very easy to judge someone else when you think they're being very prudish or closed-minded and you believe that you are very open-minded. My experience after years of working with people around this particular topic whether it's a group of older adults or a group of care providers, family members. At some point, discussions of intimacy likely end up making most of us uncomfortable. I find that people, I use the expression, they hit a wall, and that where we hit that wall looks different for every one of us. But I think we have to be prepared for the fact that something's going to gross somebody out. And we have to respect that, because we don't know where their values and beliefs are coming from. But it's important to remember that they might look different than ours. And therefore, it is really important to talk about it, which is why it is so fantastic that you've been offered this opportunity and you've all joined this talk today, because talking about it is the first step. And that leads to one of my biggest concerns in this area and in healthcare generally, is the issue of language, because we use language to label things, to label people. The number of times that I was asked, I was the only one on the outreach team when I did geriatric outreach for years in downtown Toronto. I was the one that got all the referrals for the sexually inappropriate behavior. I mean, the referrals, they were all over the map. People could do the most random things and suddenly be identified as being sexually inappropriate. And that kind of a label would then follow them. It always got transferred from file to file to file. I think we have to stop and think about the words that we use sometimes. This topic is a perfect example. I've called it intimacy and aging, but indeed, even intimacy could be meaning very different things to everybody in this audience. You might actually all have come thinking that we're going to talk about something very different. And that's okay, because that's what language does. It puts things in boxes. I'd like us to open up those boxes and try expanding and thinking about things a little more broadly. And therefore, what I do is I often in my teaching offer some examples of what language can offer. Dimitri Rewelak is a psychologist who worked at Baycrest for a number of years, and he and I have co-presented in the past. And he was often fond of saying, if physical intimacy has been an important part of self-image and coping, it remains so. And I think that that's a very important part of one of the underlying themes of the education that I offer, is that we need to know who someone was, because who they were can be a very important part of understanding why they may be doing certain things. This is actually a very basic premise in good dementia care. We hear the frame, behavior is called responsive, not challenging, not difficult. We call it responsive because they're responding to something. We hear the term, all behavior has meaning. And those of us who want to learn how to provide good dementia care are challenged to discover what the meaning is behind a behavior. And yet something that is deemed a sexual behavior is put in a separate box. And we don't take the time to try and understand the meaning of that certain behavior. And sometimes a very important part of that is understanding who the person was and what they valued and what was important to them. And is that now what they're seeking in some of what we are seeing and labeling inappropriately? Another really important definition for myself as an occupational therapist is the definition of sexual health that was created by the World Health Organization back in the 70s. This stuff isn't new. And that's why many times in my career, I felt that I'm going to, be able to put the sex teaching away, but it keeps coming back because we haven't been able to move on about some of this. And that's why I challenge all of us to really think about how we advocate on behalf of ourselves as we get older and on behalf of those that we're looking after and caring for and caring about. Sexual health, according to the World Health Organization, is the integration of somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. I do a lot of teaching to occupational therapy students, and basically this is sort of like the fundamental practice of what occupational therapy is all about. And if we think about that as what sexual health is about, then I think it's important to remember, because it can reinforce why someone, let's say as a care partner of a person with dementia, still feels the need to be sexually active, but no longer feels that they can have that kind of relationship with their partner. I actually gave an education session yesterday to a group of community older adults. It's part of a Baycrest series that they've launched recently. And there was a gentleman in the audience who actually raised his hand and was brave enough to talk about the fact that his wife is in a nursing home. She has later stage dementia. She does not know who he is. And he still feels, he's only in his 70s, and he still feels a need to be sexually active. And we talked about that as a group. And I had to tell him that if he was asking me for permission, I couldn't give him permission. But indeed, we talked a lot about what that can do to someone. And he basically wanted to know, like, is it okay that I feel like that? And I think if you think about what the research says, what does the World Health Organization say about sexual health? Yeah, it might be very important to you to want to continue to have that kind of activity in your life, to still see yourself as a sexual being. I'm not saying that you're not going to be consumed with guilt and shame because you're now being sexual with someone who's not your, partner for the past 50 years. This topic is very complicated. It's never going to be an easy fix. That can be very problematic for staff in nursing homes, but we're going to get to that in a moment. Let me share with you some of the answers that I've had to questions that I ask older adults when I speak to them. And I say, I do this kind of teaching to healthcare providers. What do you think? Is it a good topic? Should we be talking about this? And these are the kinds of responses that I get from the seniors who come to some of my sessions. Sexuality is an important aspect of seniors' lives. It's more than a physical act. It encompasses all of who we are. Indeed, there was a woman in yesterday's education session who said that it's so much more than just, sex and thinking that old people can't have sex. It's ageism generally. And that, in fact, is all very true. I've gone into long-term care homes to introduce myself to the staff at a particular unit because I've been asked to come in and do some education, and I tell them who I am and why I'm there. And on more than one occasion, I've had staff look at me and go, why do they need to talk about that? And the answer is because it's an important part of who they are. They will want me in there if they think there's a problem, but they're not prepared to even introduce the idea that it could be something that's really important for the residents that they profess to want to give the best care to. Another very old, but very, very powerful quote, in my opinion, is something that Alex Comfort said in The Joy of Sex. The things that stop you having sex with age are exactly the same as those that stop you riding a bicycle. Bad health, thinking it looks silly, or no bicycle. And so I always put that out there. You yourselves in this audience today might not think that it's relevant for you, but I think that it is really important that we have this kind of sort of common understanding of the baseline that I'm coming from, because I'm really here to say that I think this might be an important topic for many of us. And therefore, I think we have to be able to talk about it. That's not easy. And so we need some structure. We need a way to approach this conversation. One of the ways to do that is something called Plissit. Plissit is, again, an older model. And you can see that it stands for the stages of how you might address the topic of sexuality. The link at the bottom is to a very short YouTube video that I think is actually, it's really quite cute. It's a sexologist who talks about really what Plissit means. And what it stands for is the P is permission, then limited information, specific suggestions, and intensive therapy. In a situation where I'm teaching healthcare providers, we spend a lot of time talking about Blisset, because indeed, this is something that they might feel is their role. They need to actually identify and address a sexual issue, a sexual problem. The reason I always share Blisset, regardless of who I'm speaking with, is because the most important step in the Blisset model is the opening step, which is the P, permission. And you can see this slide actually shows you how the emphasis that Blisset places on each stage of the intervention, with the largest portion being right at the stop, giving permission. I often refer to it as opening the door to having a conversation. That same gentleman yesterday who talked about wanting to know if it was okay that he still felt like he wanted to have relationships while his wife was supremely cognitively impaired and in a nursing home. We needed to talk about this, and we talked about the conversations that people need to have. My experience has been, in many cases, some people just need to know that it might be okay to ask a question. I find that healthcare providers just might need some help knowing what question to ask. And as an occupational therapist, I spend a lot of time helping OT students in particular realize that they might go through a standard set of initial assessment questions, and they have this, process that they go through, and they might ask some very personal questions. OTs ask things about toileting. They ask about, whether you can wipe yourself. That's a pretty personal question. Why would we think that asking something about someone's patterns of intimacy might not be important also? And yet you will not find sexual questions included on most initial assessment forms. For occupational therapists, I can say for sure. For many other care providers, I think it's the same. So Plissit is there as a way to say, you start by just saying, what do you need to talk about? Or maybe you start, if you are the person responsible for meeting with a family member of someone who's being newly admitted to your nursing home, maybe there are some questions that you need to consider asking about the person who's coming in. And I often throw out the example of, you have a couple and one of them is being admitted to long-term care. The other partner is not. They are going to remain in the home. This couple has slept together in the same bed for over 50 years. I have been beside the same snoring, farting, kicking man for over 30 years. And now all of a sudden we're being ripped apart and I'm being put into long-term care. And then, early on, night shift does their walk around and they find me wandering around and crawling into other people's beds. And I get labeled as sexually inappropriate, and I'm immediately a problem. And it's in my chart, and they get consults to find out what's wrong with me. Did anybody ever stop to think that I just needed something warm and burping and farting and kicking whatever lying beside me? Now, I'm not saying every single person might. I use myself as an example. I actually would quite welcome the break from the burping, farting, kicking person beside me. Everybody's different, but we need to at least start to understand what the circumstances are of this person that we're now going to be responsible for caring for. And if you are the child of that person who's being moved into the nursing home, or you are the partner of that person, you need to be involved in this conversation, because you might be the only one who can help the staff understand what I am going to need. And so you need to be comfortable with that P in the Plissit model as well. And give them permission to ask the question by starting off by saying, I'm kind of wondering how she might behave in the nighttime. Those are the sorts of ways that you start the discussion. I encourage staff to ask about, changes in physical intimacy with aging. If they're, working in a clinic setting or a day treatment program where people are coming in. And in addition to all the other questions you're asking, ask them questions about intimacy. What goals do they have? Do they have goals for the relationship? This gentleman needs somebody to say it's okay to have some goals to continue to have intimate relationships, even though his wife is still alive. And there has been research done. I actually did my master's. I was fortunate enough many, many years ago to study with a prof at McMaster who had actually studied the role of caregivers of individuals in nursing homes who had dementia. And she studied the loss and the grieving and really wrote about how it was like grieving someone who had died, and yet the person isn't gone. And that's what this gentleman yesterday was talking about. Someone shared an example of when, their dad died and how their mom carried on. And he said, yeah, that was different though, because in that case, your father died. She's not dead, she's still there. But I can't have a relationship with her anymore. Everybody is going to have a slightly different example, a different concern, a different experience. And that's why it's so important that we can talk about it. And I mean, on this slide, I'm really talking about having an open and frank conversation, you know, between two people who can indeed have that conversation. I'm not pretending that it's easy. It in fact is much more complicated when we start overlaying cognitive impairment and dementia into the issue. It now becomes way more complicated. And I've seen it in all different settings. This is not easy. It's difficult. It's challenging. Language, once again, becomes very important, because as soon as we label someone as being sexually inappropriate, we treat them differently. We have to understand the meaning behind some behaviors. Just because someone appears to be masturbating in the dining room doesn't mean they're necessarily masturbating. Maybe they're itchy. And because of their dementia, they've lost that filter that told them that it's not appropriate to stick your hand down your pants when you're in a public setting. Maybe they are masturbating, and maybe we need to get them out of a public place. Is it okay to direct them to their room and let them masturbate in private? There's so many layers to something like this, but just labeling someone without trying to understand it is absolutely the wrong way to go. I think we need to appreciate relationships, and I'm not saying that's easy either, because the other thing that often happens that can make this even more complicated, as if it wasn't already, is what happens if the wife of this gentleman who's looking to, you know, find intimacy somewhere else now, and he's moving on. What if she starts crawling into bed with another woman? Staff see that, and I'm here to tell you that staff, in my opinion, have a very different approach to two women who find each other together in a bed and two men. I'm not sure why that is, but somehow two women can be cute, two men not cute. But again, stop, don't judge, take a step back and try and think about what kind of behavior we're seeing. Is this just about a need for closeness and companionship? And how many of you have had experience with care providers who won't even let two people hold hands because it might lead to something? And what are we doing to their quality of life if we forbid that kind of contact? And I'm not going to talk about COVID today, because let's have, you know, an hour without COVID thoughts. But if COVID has taught us nothing else, it has taught us how important contact and connection is. Because after 2 years of being told, stay back, don't touch, look at the harm that it's doing to individuals. We have to try and understand how we can continue to foster relationships. But again, it's not easy. We might need ethical consults. We might need to try and find out if someone can help us wade through the ethical dilemma that we might be encountering. The issue of capacity, and is somebody more capable than another? Is someone being taken advantage of? Are they more vulnerable? This is often where the very strict no comes from in staff, in facilities, in organizations, in nursing homes. It's the idea that they need to protect the individual, and that the individual is at risk because they're vulnerable. So there are some strategies. I'm not going to spend a lot of time on this, but I want to spend a bit of time talking about the fact that there are strategies. There are things that we can do. Very simply, we have to be prepared to examine our own issues. When we have a reaction to something that's happening, we need to step back and try and think about, why am I feeling icky about this? You know, I have a colleague who talks about the yuck factor. And it's kind of like he calls it yuck factor. It's me kind of saying hitting that wall. We've got to be prepared to examine our reaction to this. We also, as I've said before, have to be prepared to examine the behavior and not jump to a conclusion. And the last point on this slide can get really tricky. And the gentleman from yesterday, you know, we talked about how he can no longer talk to his wife. They didn't talk about what she might want as she was starting to decline cognitively. It's one of the big things that makes me sad about how the healthcare system has helped people prepare when getting a diagnosis of dementia. We don't sit down and start to talk about what's to come and what we want. And family members end up being asked to make decisions down the road, and they don't actually know whether they're making the right decision. Because are they making the decision based on their own values and beliefs, or what they thought the person with dementia would have wanted? And that's why I say, whenever possible, family and staff need to work together as partners in the discussion. I will tell you, sometimes the children are the biggest stumbling blocks. I've seen fractured families where we have, a couple who've been together forever. One of them is very cognitively impaired. The other one is finding a new relationship, or the person with cognitive impairment has found a relationship in the nursing home, and the kids are split. And some of them are happy the dad has been able to, find companionship, and the rest of the kids think it's disgusting. And how could he do that to their mother? This is so messy. It's not easy. And I'm sure there must be some of you in the audience who can think about your own families and the conversations that you might have had, or the conversations you're afraid to have. The gentleman yesterday said, yeah, well, I'm not ready to go to the conversation with the kids yet because it's not going to be easy. But at least we talked about the fact that at some point, maybe he needs to sit down and have the beginnings of a conversation with him, because we need to work together. We end up being adversaries. The healthcare provider on this side, the family member on that side, and you're the difficult wife, or the challenging daughter, or the kid from away. We have all kinds of labels. Remember, I told you about the language issue. We label these family members without stopping to think about how hard this might be for them. And then the families judge the staff and stop to think about how the staff just want to do their best and they think they need to protect. Working together is not easy, but it's important. I throw this slide up only because it's kind of a snapshot again from my teaching of the various ways that we need to kind of really look at how we're going to solve a problem. This is really a framework for dealing with any kind of behavior in dementia. Just because we're talking about a behavior that has a sexual nature doesn't mean the approach would be any different. I actually think there's some stages of this process that might be more important when we're talking about a sexual behavior, particularly on the right-hand side, where one of the first things after you stop and take a breath is examine your own feelings in response to the behavior, because so many times that is where the problem starts. But if I move on, when we're talking about sexual behavior, the framework that I just showed you on the previous slide is it kind of sets things out in a similar way for every kind of behavior. You start with what the particular challenge is, and then what would the strategy be that we want to use to tackle this. And this might mean that as a family, you come together because you got a call from the retirement home. And I can share this with you as a daughter-in-law of my father-in-law when he was moved into a retirement home, and the day that we got the call from the social worker because Harry had made a friend. And so the family comes together. I mean, I will use this framework when working with a group of staff who work on a particular unit in a nursing home, but it can apply even with a couple of people. So we've got challenges and we need to come up with some strategies. Don't be afraid to explore the challenges. There could be a lot of different reasons why you see a particular behavior. There might be a physical reason. There might be a psychological reason. It might be cognitive. It might be environmental. This all goes back to the previous slide with the framework. And sometimes people don't want to take this time because they worry that if they bring 4 people together and say, why is he masturbating in the dining room? They're going to get like 6 different reasons why, because 6 different people who know this individual know the person in bits and pieces, and they all have a slightly different reason for thinking that he's doing this. I say, welcome the conversation and let 6 different people come up with 6 different reasons why they think the behavior is happening. Because 6 different reasons why the behavior might be happening can lead to 6 different things we might be able to try to see if we can fix the problem. But I say fix the problem in quotations because I'm not necessarily saying that we have a problem. Remember, my own values and beliefs might have labeled this as a problem when in fact, there is no problem at all. But it's worthy of kind of letting people talk about what they think is going on, because, you know, the staff in a nursing home who really know somebody have observed things that maybe we missed. And if it's a physical issue, then maybe we can treat the physical problem. Somebody who's sticking his hands down his pants might be itchy because he's developed a urinary tract infection, or she has some kind of like yeast infection. And we need to discover the infection and treat it. There was nothing sexual about what they did. We mislabeled it because we didn't take the time to understand it. Maybe it's a psychological issue. Maybe this is the previous personality. And this is where we need the family involved, because as much as I hate to say it, sometimes it's really important to understand if dad was always a bit of a ladies' man or mom was a bit of a flirt, because if those were the kind ways that we labeled them in the past when they were younger, maybe that's part of what we're seeing now. It's important to understand that so that we don't just misjudge. Cognition, of course, if they have indeed, started to really decline cognitively, they don't understand that what they're doing or saying might be inappropriate. And us saying, don't say that, that's wrong, it's bad, trying to discipline somebody like they're 2 years old is not going to be successful. We have to try and be non-judgmental as much as it might hurt us. We have to try and, redirect them. Maybe keep things simple, help them understand that maybe not now, maybe then, maybe over here. And again, I'm not saying it's easy, but if everybody's working together, maybe we can try some things that might be successful. And then finally, in a setting where, there's a number of people maybe involved, I think it's important that we all talk about it because we all have to be on the same page. If I'm a care provider and, the person that I'm assigned to is a gentleman who gets an erection every time I give him personal care in the morning, and I basically slap his hand and tell him to stop that, it's dirty. And then the next care provider who comes in and looks after him the next day just ignores it. And then the next care provider actually giggles and thinks it's funny. How are we helping that individual who's already cognitively impaired? How are we helping them understand what the heck is going on to begin with? I think that we far too often jump in to fix something, which leads me to the issue of risk. I mentioned capacity earlier. I mentioned ethics. It is so important that we stop and think about risk. We talk about risk-benefit analysis in so many things. We talk about it in our personal life, in our finances. I'm here to tell you that I think in many cases, especially when we're talking about sexuality, we need to actually talk about a risk and a benefit, because I think it's important that we ask ourselves, what is the degree of risk? Is there a risk? Perhaps there is. Sometimes you just start with the question, is there a risk? Because once you really start to unpack it, people have trouble really coming up with a risk other than the fact that they don't like it. And that's your starting point then. Well, okay, you might not like it, but then let's talk about this, because then maybe it's not their problem, maybe it's our problem. And indeed, again, thinking about how staff respond when I say what I'm here to talk about today. And I've had people say, well, what could go wrong? They can't get pregnant. As healthy older adults, I'm here to tell you that you should be, if you're interested in continuing to be sexually active, good for you. You need to figure out, what are the barriers to you being sexually active? I'm here to tell you sexually transmitted infections are a risk. They are a real risk. Many of the older generation, the older adults that I've worked with during my career, never practiced safe sex. It wasn't something they did. They grew up knowing that they were saving themselves for marriage, and they loved their partner and they raised a family together, but safe sex wasn't something they thought about. Now you might need to get some education about safe sex, but where are you going to get that education? Because most of us can't talk about it with our family doctor. So these are the sorts of things I think we need to be able to talk about. In the case of someone with dementia, we need to be able to balance the risk against the benefit of alternatives, because if we truly in our heart believe that the intimacy is not just about intercourse, it's about connection, it's about relationship, and it's about feeling like you still have some kind of meaning in your life and you still have quality of life. And if that's what we're really about, then there is indeed benefit to being able to have those connections. And maybe what we need to do is try and figure out how to make those connections happen and not be afraid that it's always going to end in something dramatic like sexual intercourse or rape. I've had people indeed talk about the issue of rape, and I'm not saying it's not a risk. And indeed, when we're talking about capacity and two individuals where the level of capacity is different, those might be risks that we absolutely need to consider. I was asked to consult with a colleague who's working in the community, and had this come up in a retirement home that she's currently providing support to. And I mean, one of the things that we're considering is that the woman who has been involved with the gentleman is being accused of rape. He's being accused of being a sexual predator. But as she started to examine and monitor the behavior, it turns out that in fact, he's much more impaired than she is. And she's been coaxing him, and she's been directing him, and he's been following her lead. We need to intervene there because there indeed is a difference in capacity, and one of those individuals is much more vulnerable, and we do need to protect them. So again, it's not there's always the same rule. We need to be able to take the time to really examine the problem and consider the influence of the values and beliefs of everyone involved. Care partners, all of you out there, me, those of us who really want to be invested in good dementia care, we also need to have an opportunity to share our own feelings. You know, you as the partner of someone who has dementia now, you as the child of a parent who now has dementia, you might need to start to talk about some of this. And I think that we should give all of you the same opportunity that we would give the staff in a nursing home who are provided, you know, regular education. Good for this group to provide this kind of educational system for you. But do you feel that it's the right environment? You need to know that you can talk about it and not be judged. And some of the key questions to start that kind of a discussion: who really has this problem? If you identify that there is a problem. And if there is a problem and it is related to a particular behavior, have we done our homework and do we understand where this behavior is coming from? And is one person limiting someone else's needs, but based on their own values and beliefs? These are not easy questions, but they are indeed the kinds of questions that I think it's really important for us to ask. And so now I'm going to stop talking because I talk too much, and I would really love an opportunity to hear from the rest of you. Megan, should I stop sharing my?
Yeah, if you want to stop sharing so I can see your face, that would be lovely.
Okay. Hi.
How are you? Thank you so much, Sylvia. I think, you know, based on my many years working at AGI and working with older adults, I think it is a topic that the teams in general have a kind of that unsure feeling, right? Because depending on maybe it's a generational thing, maybe it's someone shy, or it could be someone who's very religious, right?
Yes.
And you don't really approach it. So I guess what my takeaway from today is start asking questions, being open and honest, because as you said, you know, we're talking about toileting and we need to approach it in a very sensitive way, because we also don't know about the person's past. One thing that we see a lot is that people do get labeled sexually inappropriate very often.
Yeah.
And this could be either in a home setting or in a long-term care setting, where maybe we could be wearing something, the person who's providing care is wearing something that might be seen as an invitation. So for example, I'm wearing a V-neck shirt, a sweater today. So if it's a little bit lower, you know, and I'm helping someone undress to change for maybe a shower, you know, and the person goes and sees that maybe as an invitation to, you know, that maybe we want to be intimate or close in some ways. And then all of a sudden they get this label. And what is your, and of course, maybe the spouse is embarrassed and ashamed. How would you handle this situation to make it a little bit more easier to talk about, I guess?
Well, you know what, Megan, I mean, it's a great example. I can absolutely say that one of the things that often leads to is, so, you know, the spouse feels embarrassed because I can't believe that, you know, he just did that, whatever he did. And then you might actually feel guilty. You might feel that it's your fault. I can remember working with staff who'd been caring for a particular gentleman for a very long time in a nursing home, and he had declined cognitively, and they started really being concerned about his behavior. And when he became sexually inappropriate, they were, it broke their hearts because they felt a real bond with this gentleman. And as I started to explore, when it was happening, and they talked about transferring him in and out of his wheelchair, I had them show me how they were doing it. And we had this little gentleman in a chair and these two personal support workers, one on each side of him, who basically, and I'm just going to be kind of graphic about it. Indeed, doesn't even matter what you're wearing. They would be one of them under him here, the other one under him here, and literally they were shoving their breasts into his face. And he was way past the point where he knew that that was wrong. He would reach for those breasts. And one of the girls, God bless her, was quite buxom.
Mhm.
And the biggest problem was that they were horrified that he was doing this to them, but they both also felt that it was their fault. And I think that that's really an important part of the unpacking process. No matter how much we think that we know that someone with dementia, might not really mean what they say, or they don't know what they're doing, certain behaviors hit us very, very personally. Someone makes a racist comment, and it just gets at our, deepest soul. And then we realize that even though at an intellectual level, I know that they don't mean it, at a more emotional level, it hurts me. I think that this is a perfect example of how we need everybody to kind of talk about it. The wife needs to know that she doesn't need to be ashamed. We need to talk about what he's done. And I would want to try and spend some time with you as the person who might have, felt that he was coming on to you, and talk about, I'm not going to say there's an easy answer, Megan. Some people might actually say, don't dress like that. Depending on how that's presented, that can really cause a problem in terms of that relationship with the care provider, because now you're telling me that I can only dress a certain way. Some staff would automatically want to change the way they're dressing, but it doesn't mean that the individual isn't. Don't forget, what did you say you were doing? You were about to give the gentleman a shower. So again, we have to stop and think about, what is it that I'm doing? I'm this young person, I'm pleasant, I care for them, they love to see me, and now I just got them naked.
Yeah. Absolutely. I think we also have to think about the different sides, where you said tell in this case that the wife not to be necessarily ashamed as to what's happening. It's very often that we do joke a lot about someone being very flirty and they're like very kind of it's just, the fact that the person is flirting, and then there's a partner or even an adult child who's watching their parent becoming very flirtatious with someone else. It's really, the staff themselves or whoever's around them might think that this is like cute and
Yes.
lovely and stuff like that. And I'm watching my language as well. But, it also, it's hard to adjust those roles and those relationships and understand it. And I think that everyone needs to be aware of what that, both sides of the situation, and sensitive to that.
Yeah.
I have a question, Sylvia, about, it says, well, it's not really a question, a statement. I mean, the person couldn't stay, but it says, my husband is extremely affectionate and needs to caress and touch. But the most interesting is that he often tells her that he has to empty his reservoir. So I guess I'm going to follow up with this question is, what happens with a person with maybe has a cognitive impairment or someone with dementia is really seeking out that affection, and then the other person is really kind of withdrawing because they don't have that same connection or attachment, and maybe just that's always the way it's been in their relationship. Is there any advice that you would give that person who's kind of withdrawing to help support that person's need?
Oh, wow. That's a great question. And again, I mean, there's so many layers. I think the first thing is, and I'm not sure if we're going all the way to when they actually do want to empty their reservoir, but I think that again, the need for the physical contact and the stroking and the companionship. Maybe it wasn't the most sort of obvious part of the relationship when the partners were younger together. We get into our lives and we're busy and we're raising a family and we're work and we're tired. And then, time passes and all of a sudden, I think most of us, it's like, I don't know where I certainly don't know where the last 2 years went. I don't really know where the last 5 or 10 years went. And now here we are, things have changed for one of us much more than for the other one. Doesn't necessarily mean that, that the need for companionship and the need for intimacy, and it doesn't have to be full-blown intercourse, there might still be a need for intimacy. If I don't feel like I can meet my partner's needs fully to emptying the reservoir, to having intercourse, maybe that's okay if I'm still okay to sit with them, to hold hands with them. Maybe we can still have some companionship. I mean, I will tell you, this is where this can get really, really complicated. I remember giving a talk many years ago, and there was a woman in the audience. It was for a chapter of the Alzheimer's Society. And a woman afterwards came up to me, and basically she was a volunteer with the chapter of the Alzheimer's Society now, at the time of the talk. She had cared for her husband while he declined at home. And then when it was really too difficult for her, he moved into a nursing home. And he died about a year after he went into the home. And she had some support from the Alzheimer's Society as he was declining. And then she joined them as a volunteer after he died. She spoke to me and she cried a lot. And I still remember and we talked about the fact that I would use her story in the future because it seemed very powerful to me. Her husband became very sexually aggressive as he declined cognitively and sought sex from her in the last year that she cared for him at home at a level that they'd never had when they were married. She was pretty sure that he no longer knew who she was. He just insisted on sex. And she went along with it, but she hated every moment of it because she didn't actually feel like they were still partners. She never told anybody. She didn't know what to do. She never told anybody. I spent a lot of time talking to her about how I feel that all of us let her down. I mean, she was getting support from the Alzheimer's Society, and not once in the several years of his deterioration at home did there ever seem to be an opportunity for anybody to really tap into how she was doing and how things were going with him. And I think that that's a really important thing because, again, if you're not comfortable with the relationship, you need to talk to somebody about it. And maybe there are ways that we can help the person who's maybe having not just a need for companionship. Maybe that's okay. Maybe I'm okay when I'm with the person to sit with them, to hold hands. Maybe we can watch our favorite television shows together, listen to music, dance, give them that, maybe, close dancing, not the kind of dancing that the young people do today. So that those kinds of things that used to be part of what was our relationship are still part of the relationship. And maybe we need some help from an expert to help him or her with the actual sexual release that they also want that I can no longer give them. And both parties are going to need help with that. Somebody's going to have to be comfortable figuring out. I mean, I'll be honest, I've worked with couples where the answer has been somebody else physically releasing the person, giving them an orgasm, leading them to orgasm, because that's the only way that high level of tension can be released. I had a male colleague who would sometimes do co-education with me, and he would clearly say that sometimes, depending on circumstances, that actual ejaculation, sexual release, and I'm not saying that it's always true for the male, but sometimes that's the only way to release other tensions in the body. So maybe we need to find a way to maybe help him masturbate. And you can still have that close relationship. Maybe you stimulate him so that he comes to orgasm, but you don't have to actually physically have intercourse. And then you are also going to need some help because you are going to feel guilty about not wanting to have that, that full-blown relationship. And that's going to interfere with how you then if you're feeling guilty about what you think is going to come, you're not going to want to sit and hold hands because you're afraid of what's to come. It's so complicated. I'm sorry, I'm probably not even remotely answering the question. It's just there's so many different layers to something like this. And I just feel like so much of it falls on those of us who might be there to support both of those individuals, whether we're, the staff, sorry, Megan, if you get inundated with referrals, but whether you're the staff in a program that offers support to people, whether you're staff caring for someone with dementia in a nursing home, whether you're a PSW coming into a home, we need to start to be able to recognize situations that maybe need some exploring and help with the exploration. We don't have to go from permission all the way down to intensive therapy. There's other people out there that could help us with that. But people need to be able to talk about it, because the hangups that we have about this interfere with, and I think about, a couple like, I can't even sit with him now because I'm afraid of what he's going to think that means. And therefore, I'm not sitting with him anymore. And that, oh my goodness, there you go. Now you've just destroyed the relationship of two different people because I didn't get I didn't get a chance to ask, to talk it through. Sometimes just talking about it is a really important start, and being able to unload. Again, I think of the lady who never, in the years that she went through this with her husband, never felt that she had a safe space to talk to anybody about what she was going through. And I feel so badly for both of them. I think I should stop talking. I'm very conscious of the time. I'm sorry, Megan.
Sylvia, I love your passion. I know Francine, I think, is still there and wants to talk, so I'm going to allow her to talk. But I just, the fact that you were able to present today and open the conversation, I think is so important, because it's really a taboo topic, right? That a lot of people just don't address. Even if it's, they haven't been intimate for whatever, again, that is defined for that couple in years, and all of a sudden they go into a residential care, and all of a sudden things change. We need to feel comfortable to open the topic, but it goes both ways. Not only the family member, the spouse, whoever, but also the staff. They need to be open to having these conversations. And I know in the past, it's a dialogue to have with whoever is working with your team to say, are you comfortable? And if you're not, self-reflect, as you said. So yeah. I'm going to allow Francine. I've never really actually, I'm in the tech. I'm going to press on a button. See if Francine, can you speak? You just had.
Yes. Can you hear me?
Yes, we can. Go ahead.
I truly think this is one of the best lectures, talks I've heard in a long time. And when I was a student nurse many years ago, I worked in a facility here in Montreal, and we had an issue where a man and a woman was found, and oh my God, they were ostracized. It was just horrible. It was so sad. I do feel that not only occupational therapists, I really feel that nurses, doctors, this is a lecture that all health professionals should really be, heard. It's amazing. And my thoughts and feelings are, I wonder how the Woodstock generation will feel about sexuality when they're older. I'm kind of hoping that maybe we're going to be freer.
You know what, Francine? I mean, thank you. I hope so as well. I'm not convinced, because look at the children of these parents. The children have the same kind of hangups that we say the older generation has. And I think that's really disappointing. And that's why I want us to have these conversations, because many of us do think that the flower children from the 60s are going to have a completely different view of this when they themselves are in their 80s. I don't know. I hope so. Let's hope. We can hope.
Yeah. So
thank you so much. This has to be such a special hour. Thank you.
Thank you, Francine.
Thank you for sharing.
So I am going to wrap up. I just want to say, we've had glowing comments. in the chats, praising you, Sylvia, thanking you for this enlightening talk, something that is, again, as I said, taboo. And we need to open the conversation up more further. I'm sure people are going to ask for a part 2 in the future.
If people want to keep talking, I can talk about this all day.
Just appreciate your honesty and openness, and you're willing to challenge language, challenge, diving deeper into the meanings behind the behavior, and not just assuming that that's a dirty old person, acting out or some, there's reasons why things are happening. So thank you so much.
Thank you.
I see again, yeah, now everyone's saying they want a part 2. We'll take you on the road to Montreal. How's that?
Okay, if we're gonna have a part 2, it has to be more of everybody else talking and less of me talking.
Okay, done. So, okay, Sylvia, thank you, everyone. And if you have any questions or want any follow-ups, please reach out to AGI. We're here. We can talk about intimacy, sexuality, whatever you want, okay?
Great.
Have a great day. Thank you so much.
Thanks, everyone.
Bye, everyone.